If you see any of these symptoms, call 911. Don't let the person wait. It's better to call 911 and have it turn out to not be a stroke than not call 911 and turn out to be a stroke, but you waited too long. So that's what we're trying to accomplish.
The price is too high of waiting.
It really is, you know, and we know that now. It's
and I'm
something
thinking the thing that it could, because my mother has these symptoms sometimes, and she's been checked, and it's turned out that it's a migraine. That's probably the most common thing that it could be, that it's not a stroke. But still, wouldn't you be happy to go to the emergency room and find out it was only a migraine?
Oh, absolutely.
Why not go and find that out, than stay home and maybe
absolutely, you know, we
miss
probably
a golden opportunity?
Over half of the people that show up with some sort of symptom, it turns out not to be a stroke.
Well, that's good news.
Better to find out that way and go through the process. Because again, if it's happening, we potentially have the ability to stop the process and potentially reverse it if we can.
So face changes, arms and legs, and speech are the key.
They're the key. And it's not necessarily, I mean, anyone can pick out the dramatic. It's not necessarily the dramatic we're looking for, it's the subtle. If something just doesn't feel right, and it's on one side of your body or it affects your speech, that's when you want to get checked 24 hours a day. The system works 24 hours a day.
Right,
and
3
don't wait.
a.m. too.
Yeah, don't go to bed and hope you wake up feeling better. That, in fact, what we find in our research, I say that facetiously, but that's what we find. A great number of people that arrive to our emergency room, they go to bed and think they're going to wake up in the morning, they'll feel better. That's not necessarily the case. Don't be afraid to bother the system if you think you're bothering it 24 hours a day.
So if people recognize these signals, get to the emergency room as fast as possible. What will happen next? How do you diagnose? And I want to not be sure we don't miss the bleed, because that can, in fact, I was going to just ask you, the headache that you might be one of those symptoms is more with the bleed than a clot.
Yes. Yeah,
because there's pressure from
exactly.
the
People
blood.
who have a stroke that's due to a blockage usually don't have a headache. People who have a stroke that's due to bleeding in their head, again, because it's bleeding and it's putting pressure on the inside, will most likely have a headache. So if you have a sudden severe headache, unexpected, associated with something in your body, you need to come to the emergency department. The treatment is so different. It's so different. And what we would do is different. So when you ask, like, what would happen? What you should expect to happen if you come to the hospital with symptoms of a stroke is that we live under a very finely tuned process that we're held accountable to.
Like a protocol.
Protocol, where we have to be able to assess someone quickly within 25 minutes of their arrival, and that includes getting the CAT scan of their head. And there are other things that we do to make sure that something else isn't going on that could mimic a stroke. That happens within the first 25 minutes, which is pretty quick. And then within a total of the first 40 minutes, we have the results of that CAT scan and have already spoken to a neurologist on the phone. And while that's happening, the way our system works is if someone arrives to the emergency department with symptoms of a stroke, we actually mix the medicine, the clot-busting medicine, as soon as they arrive, in case we need it. Because our goal is to have the person arrive to our door, and if they fit the criteria to be able to receive the medicine, then we should start that medicine going into their body within 60 minutes of their arrival. That's a lot of processes that have to happen in that hour. So if you come, you would expect to be put into a room with a lot of equipment, with a lot of people mulling around you and moving around you and moving you through the emergency department into the radiology department and back in a very short period of time. And then all of a sudden you're on hold at that point. We spend a lot of time talking with the patient. We do multiple assessments to try to figure out the severity of the stroke. But what's really important in that process too, and what's really important why people need to call 911 is we work very closely with the EMS system, the paramedics. If you're having a stroke or symptoms of a stroke and you call 911, when they do their initial assessment, and they're usually assessing someone while they're doing their normal processes around a person, packaging them up to come to the hospital, we get a phone call from them. And if they tell us we have someone who we think might be having a stroke and the symptoms started and they give us a time period.
Like an hour and a half ago or something.
Within the 3-hour window, we start our process waiting for the person to come to the emergency department. We're mixing the medication, we're calling the CAT scan, radiology department to the CAT scanner, so if they have someone on the table, if they have to take them off, they could take them off the table in preparation for us. We open up a room and we have all our equipment necessary waiting for the person to come in. That's our goal. Mm. We hit that almost every time. So it takes, every minute counts. And that takes a couple minutes off our process. So the process starts with a 911 call. So that's what you should expect to see. Mm-hmm. And then what happens is, if we find that the person is able to receive TPA and agree to it, and the clinical situation fits all the criteria to be able to do it, we infuse the medicine, we put the medicine into the system, and then we watch the patient for a while. We actually have an arrangement right now that every time we use this medicine, we transfer the patient into a tertiary care center for a couple of reasons.
So they leave Melrose, Wakefield, or
right now
Lawrence
they do.
Memorial?
Right now they do. For the next couple of years, they'll continue to do that. Because one complication of giving a patient a clot buster is that the person could bleed.
The purpose of the medicine is to
Open
liquefy everything, and
exactly.
so it can cause bleeding.
And it can cause bleeding. And about 11% of people can have a bleed. We tend to believe that if that is a potential, and 11% is high, mm-hmm. that a person should spend the first 24 or 48 hours in a place that if in fact they do have bleeding, something can be done about it immediately.
And something means usually surgery.
Usually surgery. What we are finding, though...
That's the difference between a clot and a bleed.
Absolutely.
One may involve surgery.
Absolutely. I mean, some people would say, well, if you give me this medicine, you may cause a bleed. Absolutely. 11% of the time we will. But 89% of the time we won't. What we are finding, though, and I think this will be the next step in all this, is we won't need to send people into a tertiary care center unless they do have a bleed. Because the bleeds that people have are being handled conservatively right now, which means most of them are not being handled by surgery. They're just being watched and letting the body handle it on their own. If the research still goes in that way, we'll be able to just keep these patients at Melrose, Wakefield, and Lawrence Memorial from day one till the day they're discharged.
And if the educational program works, they'll be in much sooner.
Perfect.
And we'll be having a higher % of success.
Perfect. This is all about educating people. Mm-hmm. And then people should depend on the medical system to give them what they need. Mm-hmm. That's the expectation. It's all about showing up mm-hmm. on time and to get the best chance that mm-hmm. you can to not have the symptoms of a stroke.
Mm. If you miss this, I mean, we don't have much time left, but if this time limit is missed and a person has a stroke for longer than these meds work mm-hmm. or can be used safely, then they have this paralysis often or speech damage
yes.
that will be the result of
yes.
brain damage that's not been reversed fast enough.
Yes.
So then we have a whole rehab system
well, we do,
that
but
helps people. But
just so you know also...
Which would you choose?
Well,
I would choose not to have...
I would choose the medication. Mm-hmm. And just so people know also, the medication we give is a 3-hour window. Mm-hmm. The way technology is changing, there is potentially a 6-hour window to be the recipient of some of the technology in a tertiary care center. We have a system in place at Melrose and at Lawrence, just like other primary stroke centers, where if someone is within the 6-hour window, then there are technologies, surgical technologies, that can be used on people where the clot can actually be taken out. It can be broken apart mechanically by putting a wire up into the arteries of the brain, or the clot can be found and the medicine to open up the clot can be placed right on the clot by going up through the arteries of the vein. Essentially what's done for a heart attack is now being done, or it's tending to be done, for a brain attack or a stroke. And the larger tertiary care centers have that capability. So in our process, we've worked out those transfer agreements where if someone is in with that window and talking to the people at the tertiary care centers, and they feel they can benefit, that what they can do can benefit the patient, we will transfer the patient down also.
So it's something important for people to realize that we have these magic medicines, but we also have 9 million backup methods of solving the problem. It's just that this one is quickest, easiest, least risky.
Well, it's the one that is able to be given in any hospital, and in some areas of the country actually given by the paramedics.
Wow.
So the world is going that way. But even with the advances technology allows, it's still based on timing. Still based on getting in time. And if I were on the table, you asked the question, what would you choose? The medicine or potential to not reverse the symptoms of stroke and rehab? I think I would take the medicine. I think I would. Because if you have a major deficit and you choose not to take the medicine, you have the major deficit.
And like you said, 24 hours, you may have more.
Absolutely.
So you don't really know.
So it is a good chance.
So we have probably a minute left, and I think we're ending on the big point, which is people have in their hands the power to make this work the best.
Absolutely. You know, there's a certain understanding that people have, and they just have to accept it. They have to understand what they're looking for.
Give up wishful thinking.
Give up wishful thinking. You have to accept the fact this could be happening, and that there's a medical system out there that could help you. It's all based on timing.
And better safe than sorry.
Better safe than sorry.
Our grandmothers would have said that. We should listen.
Absolutely. And watching over everyone around us and using the system that's out there, using 911. It's a potential savior. You know, and that's what we're looking for with this program.
And since stroke is a high cause of American loss of life, we need to pay attention.
Well, it's a life changer. You know, when people have a stroke with a deficit, their whole life changes and their whole family's life changes. It's not just the stroke itself. The whole way of functioning is going to change from that moment on.
So be your best advocate. And I have to say thank you for being with us. It's been very interesting, and I hope that everyone listens and pays attention, and don't worry about being embarrassed. Go to the emergency room.
Thank you for the opportunity.